All right, everyone. Welcome to our Echo. We'll go ahead and get started. My name is Jody West, and I am the coordinator of the Echo and the program manager for the provider-to-provider consultation line. This is our fifth Echo series focused on pediatric mental health. And this is, I just noticed I have the wrong slide. This should be pediatric mental health tele-echo. But today is our first session for this year. So we'll go ahead and get started. Just to tell you a little bit about what we do with this focuses on a didactic presentation followed by a case presentation, and we ask that everyone that is here to participate. This is the rough agenda. We'll do our best to stay to this timeline. It goes by quickly. And so we'll start with introductions of our hub team, followed by a didactic presentation by Dr. Kirikoff, followed by a case presentation by Dr. Queen. And we'll have Dr. Olivier will lead us through clarifying questions. And as a team, we'll come up with some recommendations for Dr. Queen. And then we'll wrap up the session and have a few announcements. I'll go ahead and introduce myself again. I am Jody West. I am the program manager for the provider-to-provider consultation line. We provide consultation to providers focused on pediatric mental health or perinatal mental health, depending on the needs of your patient or your client. You can give us a call at any time. Those are our numbers. We also have an online consultation request form. If you scan this QR code, it brings you to our registration page. And if you do that, then you'll get access to monthly newsletters that have our trainings that we have available, like the Echo, as well as other trainings, which we have quite a few coming up this year. So I'm going to go ahead and leave this slide up and turn it over to Dr. Olivier, who will lead us through the rest of the introductions.
Hey, good afternoon, everybody, and thank y'all for joining us for our first session for this season. I'm Dr. Olivier. I'm returning as the ECHO facilitator for these sessions, which means I try to help us stay on time and on task. I'm also the psychiatrist as part of the hub team. So you'll see in each of these sessions, we have a hub team of experts that represent various mental health or pediatric fields for each of these sessions. So we have pediatrics represented, psychiatry represented, nursing, and social work. And so I am the expert for psychiatry in these sessions. I'm going to ask our hub team of experts to each introduce themselves, starting with Ashley Hutchins.
Hi, everybody. My name is Ashley Hutchins. This is my third year with Echo Pediatric Team, and I am a psychiatric nurse practitioner in Lafayette, Louisiana.
Thanks, Ashley. And how about Dr. Queen?
All right, I'm Dr. Queen. I'm a general pediatrician, also board certified in obesity medicine, but I have a special interest in mental health. And this is my third year being on the faculty. So thanks for having me.
Awesome. And y'all met Jody. She's representing our social workers. And we also have Lena Reget too.
Hi, everybody. My name is Lena Reget, one of the social workers and mental health specialists for PPCL, and I just help a lot with the IT and planning for this Echo. Good to be here.
All right. Thank you all, Hub team. I'm going to turn it over for the next 20 minutes to Dr. Kirikoff, who volunteered to be our first presenter. So Dr. Kirikoff, I ask you to introduce yourself to our group and take it away.
Okay, thank you so much for having me. Dr. Catherine, or I go by Katie Kirikoff. I'm a neuropsychologist and medical psychologist. I'm a prescribing psychologist. I have on the slide here my colleague, Dr. Rothbaum. We are the two neuropsychologists here. We actually went to graduate school in Philadelphia together and both came here for fellowship. Didn't realize we were both applying to New Orleans and ended up getting matched here. We were the only two from our cohort that even applied outside the Northeast. So somehow we both ended up in New Orleans, and we've been here for over 15 years. So I'm very glad to be able to talk about our services. I recognize that not everybody might be aware of the things that we offer, so I'm really glad to be able to go over those things. You can do the next slide. Okay, so a little bit about our role. We have several different roles kind of evolved over the years. We spend a lot of our time here doing outpatient evaluations. These can be either brief or full evaluations, and I'll talk about those differences in a minute. We are in concussion clinic with physical medicine and rehab every Wednesday and twice a week during our busy football season. We offer medication management services for the patients that we've already evaluated. We complete inpatient consults, and we supervise graduate students in psychology. And something new we just started rolling out are e-consults. So we've started rolling this out to some of our pediatrician groups, and hopefully we can expand. So this will allow pediatricians to directly consult us with any questions for a specific patient about assessment or medication. We already do some of this service, but this is allowing us to formalize it and accounting for our time. Okay, next slide. Okay, so a little bit more about our outpatient evaluations. We typically start evaluations at school age, about 5 years of age, when kids are transitioning into kindergarten. And we will continue to assess until the patients are in early adulthood, about 21 years of age. Patients must have a medical diagnosis that would affect cognition or behaviors. So common diagnoses would be things like epilepsy, stroke, Tourette's, traumatic brain injury, genetic conditions like neurofibromatosis, Down syndrome, 22q. We also see brain tumor, stroke, prenatal exposure to drug or alcohol, and premature birth before 34 weeks. So our most common referral sources are neurology, PM&R, genetics, neurosurgery, oncology, and pediatricians. So it's important to note that the primary reason for the referral should be evaluation. We will take medication, we will offer medication management to many after an assessment, but we do not take direct medication management referrals. We also don't take primary autism referrals. We will send those to the autism center. We very often do see autism with our patients, and we can diagnose it if it's clear, or we'll send them to our autism center for more testing. We don't offer therapy, and we don't accept referrals that are just for learning disability. We will evaluate for learning disability as part of a broader evaluation, but we can't accept referrals if the primary or only question is learning disability, mostly because insurance will not pay us to do those. So we usually have to refer those to the schools or to the community, like a private practice psychologist would do those. Okay, so next I'm going to talk about evaluation steps. So from start to finish, these are some of the steps. So at first, we will review the referral. Our coordinator may do a telephone screening with the family or call the referring doctor if there's some question about if it's appropriate for us. We also always review clinic notes. So if they're an Epic, we'll take a look, but if not, please send those to us. If not appropriate, we will try to refer to a more appropriate provider in-house if possible. We have psychologists here who, of course, do our autism assessments, and we have other psychologists who do assessment for patients who don't have a medical diagnosis that we would need. Of note, if for concussion referrals, we will only see those in concussion clinic. If they don't have an abnormal neuroimage, like a abnormal MRI of the brain or EEG that suggests a more serious injury, we won't see those kids for full evals. We will see them in concussion clinic where we do cognitive testing in that clinic that's evidence-based to look at their concussion recovery. So if we've accepted the referral, we think it's appropriate for us, then we'll decide if it should be a full evaluation or a brief evaluation. Most are full evaluations, and those involve 3 visits. Our first visit is a telehealth interview with the neuropsychologist, the caregiver, and the patient. The second visit is a full day testing with our psychometrist. It's important to note that this is the only in-person visit, and it starts at about 8:30 in the morning, wraps up about 3 in the afternoon with about an hour for lunch. If the families are coming from far, then we will recommend that they come in the night before, and we have 2 lodging options on campus that can be coordinated with social services. Our third visit is a telehealth feedback a few weeks after testing, once the report is ready. And so for young kids, they're not usually included. It's usually just the parent only until the child gets into adolescence. So for our brief evaluations, those are for patients that have either an acute change in functioning, like an encephalitis, or for patients where intellectual impairment seems likely, or for our patients who we feel like are not going to be able to cooperate with a full day, like our very ADHD kids. So during brief evaluations, we will do interview, testing, and often feedback all in the same day, and that's about a 2-hour appointment. Okay, so next, I'll go over the domains. Well, just take a look at them. I mean, these are a comprehensive neuropsychological assessment looks at all these different domains of functioning. So of these, patients are most often referred to us for concerns about attention, memory, or academics. And because it's such a common referral reason, I wanted to go over memory real quick. Children almost never have true memory problems like in a dementia. It's usually inattention and forgetfulness for daily information, like what did they eat for lunch. It's not that they're forgetting big events or big parts of their memory. It's just that they never paid attention to begin with. True memory deficits in kids can be seen with particular medical conditions like an anoxic brain injury, but that's very, very rare. So we'll go through all these different domains during testing. And then the next slide talks about common diagnoses. So these are like the common outcomes. And so major or mild neurocognitive disorder, these are our catch-all labels as neuropsychologists, and it means a significant or a modest cognitive problem due to a known medical diagnosis. The issues reflect a change in functioning, as in the case of a traumatic brain injury. Neurodevelopmental disorder is another catch-all that we use for medical diagnoses from birth or the early developmental period, like a genetic diagnosis or prenatal exposure or cerebral palsy, where there's been no discrete change in the patient's functioning. So these labels themselves don't have a lot of inherent meaning. The meaning will be in what weaknesses or deficits that we list next to that diagnosis. So whenever possible, we try to use these more commonly understood diagnoses to enable services, and those are listed there. I won't read through those, but those are the other ones that we often use. But I will talk a little bit next about intellectual developmental disorder. This is pretty commonly something we've often diagnosed. It was previously known as intellectual disability. It's diagnosed when somebody's IQ is low and when there are delays in adaptive behaviors or independent living skills. So a common course is that there's often a very, early developmental delay, and then they're receiving services at school under the label of global developmental delay. They often have very strong rote skills. They learn vocabulary, spelling words very well, for instance, but they have increasing difficulty as they progress through school and the abstract reasoning deficits become more obvious. So other signs we look for are things like being naive, unable to use money, their preferred interests and friends are much younger, and their younger siblings might be surpassing them, and they're unable to respond in emergencies. So patients are often, or the individuals are often unaware of their limits, which makes setting limits very hard. It makes things like social media use and driving concerns for us. And so when they changed the diagnosis to intellectual developmental disorder, they eliminated the IQ score ranges, but I still consider that, I still think about these. So as far as severity, mild would be an IQ of 55 to 69. These individuals may seem typical in some situations, very structured situations, whereas for somebody with moderate, which is 40 to 54, or severe, an IQ, which is an IQ of 25 to 39, they seem much more obviously impaired. So the next diagnosis I'll go over quickly is borderline intellectual functioning. I shouldn't have said it's a diagnosis because it's actually a classification, not an official diagnosis in the DSM. And so this is where there's a gray area where the individual's IQ falls between intellectual impairment and normal. IQ scores are between 70 and 79 usually. It's about 12% of the population. It's pretty under-recognized. And these individuals will appear normal for the most part, but school is a persistent struggle. They're sometimes labeled as slow learners. They have difficulties in all subjects, which is what differentiates it from someone with a specific learning disability, is that it's all subjects. And again, this is another one that's hard on parents. They know their child's limits, but often not recognized, and they don't qualify for services like an IEP. Okay. So I'm going to go through quickly a few medical diagnoses and their common profiles. So for spina bifida, we typically see a low average to average IQ. Verbal skills like rote learning are often stronger than nonverbal skills. They have very high rates of ADHD and math disabilities, and this profile is even more pronounced when there's a history of hydrocephalus. So for periventricular leukomalacia, which is injury to the white matter, often seen in preterm infants, it's very similar IQ to spina bifida, similar profile, but the IQ can be more variable. They can have more severe vision impairment. Both of these diagnoses often present with mental inflexibility. They want to do things their way. They get upset with change. They can be like a broken record. They also have some sensory issues. And so a lot of times we're faced with the question with these kids, is it autism? And sometimes we do make the diagnosis if they have sufficient symptoms of autism, sort of regardless of an underlying medical condition, we will make those diagnoses. And for these kids, we're looking at the quality of their social functioning and the severity of their sensory impairments to help us make that differential. So the next group of medical diagnoses is TBI and epilepsy. Both can be either diffuse or focal, depending upon the injury type or the seizure onset. So generalized epilepsy and diffuse axonal injury, we're seeing general things like inattention, slow processing speed, and emotional behavioral issues. When it's more left hemisphere, we're seeing verbal memory issues, greater language problems. When it's the right hemisphere, more visual spatial, visual memory deficits. When it's the frontal lobes, a lot of personality issues, behavior problems, and ADHD is very common for both these diagnoses. Another one that I wanted to mention quickly was in utero exposure to alcohol and or drugs. IQ can be average to borderline impaired. The daily functioning is more impaired than their IQ usually. They have ADHD plus extreme impulsivity usually. And we often hear that they don't get cause and effect. Consequences don't work. They can be overly social or friendly, and they again have extreme impulsivity. So we feel like this is probably pretty under-recognized in Louisiana. A lot of time it's complicated by the fact that they may be adopted. So we may not have that prenatal history, or maybe there's some trauma attachment issues also. So it would be great if we could increase the number of kids that are screened for this, starting by asking about, use during pregnancy. And then this is a checklist, and I put a link to it, but this is one that's called the alcohol-related neurodevelopmental behavior checklist. So something like that, just to sort of help screen, would be really helpful. Okay. And then the last sort of medical diagnosis with their profile is some of these, neurofibromatosis has high rates of learning disabilities and ADHD, about 30 to 50%. They can have language and broad intellectual impairments. And Tourette's, we see lots of ADHD, OCD, and anxiety. All right, so once we've gone through the assessment, made our diagnosis, and we're on to the recommendations. So these are sort of some of our common recommendations that we'll make at the conclusion of our evaluations. One could be recommend for medication management. As I said at the beginning, we're prescribing psychologists, so we have postdoctoral master's degrees in psychopharmacology. We can prescribe with agreement or concurrence from a medical provider. This is most often the pediatricians. Our specialists here don't typically manage ADHD medication, and they would be unable to take over refills once the patient is stable, which is our goal. We're typically short term, so we can see more patients. We're most often prescribing for ADHD. Sometimes it's depression, anxiety. And because we're a short-term model, we aren't seeing severe or chronic mental illness like psychosis or bipolar disorder. We're very commonly referring to our therapists, our speech and occupational therapists. We're recommending school advocacy, like Families Helping Families. We recommend community resources like OCDD. College programs. In Louisiana, there are about 10 college programs for individuals with intellectual disabilities that we typically recommend. We suggest seeking legal advice for our patients with intellectual impairment, either looking into things like established supported decision making or continuing tutorship. We'll recommend, we'll refer for psychotherapy if indicated, and we'll refer for additional autism testing if we can't answer that question. Okay, so I wanted to sort of wrap up by kind of sharing some of the guiding principles that we've sort of internalized from working with this group for about 15 years. First one is stay in school. Regardless of the medical issues, we recommend staying in school and getting back to school as soon as possible. It's important for cognitive recovery, helps socially, emotionally, and behaviorally. So that's something we're always advocating for. And while we aren't therapists, we recognize that assessments can be a therapeutic process. Caregivers almost always know their kids best. They feel misunderstood, especially when their kids are very medically complex. However, it can be a process for them to cope with any significant cognitive issues that their child may have. They, early on, they often want to do as much intervention as possible, which we, support. But over time, they might need help kind of recognizing the child's limitations and that those aren't due to any failure on their part as a parent. Their child has a different brain. And so we try to encourage focusing on the child's personal progress and, worrying less about where they should be based on their chronological age. And so we can facilitate this process when we repeat assessments every 2 to 3 years. We don't necessarily need to do this if a patient is very low functioning, but for our kids, we generally like to see them every couple of years so we can kind of help families through this process. On the same note, parents almost always want to do almost everything except for medication unless their child is very out of control, which we get. They're usually open to the idea after we complete our assessments, but sometimes they aren't there yet. And we try to go with that. We try to leave the door open. We give them education that, especially because their child has neurological issues, they very well might need a medication to control some of their attention issues. And they're often very concerned about adding a medication if the child is already on medications for another diagnosis like a seizure disorder. And so we have quick access to all their specialists. We always get their blessing, and they're very much on board with treating both the medical condition and any cognitive or behavioral comorbidity. Another thing to note about how we practice here is that we're focused on function, not causality. So we're less focused on things, answering questions like, is it the epilepsy or the brain injury causing this specific issue? Things are usually multifactorial. We aren't forensic neuropsychologists. Those people exist and they get paid a lot more money. And so we'll let them do that job. But for us, we're more focused on clinically where the child is and, how to get them to the next step. We're always thinking long term. It's never too early to start discussing transition to adulthood and future goals. We start discussing interests that the child might have as early as elementary school, and we start to hone in on transition planning, during middle and high school. And then the last thing we always try to do is communicate with teams as much as possible in between assessments if we need to. Talking with specialists or pediatricians really helps us be on the same page and have a clear path forward. So that's why I'm so glad to have been here today. So thank you for having me. The last is just my contact information. If you don't have Epic, there's my email. If anybody has any questions, happy to answer any. But thank you.
Awesome. Thank you, Dr. Kiriko.
You're welcome.
It was very informative. Quick question for me. Do you take referrals